Hello, my dear colleagues. I'm very much thankful to the SciTech conference committee members and thank you for having me here. So, I'll be discussing about a very known topic that is severe aortic stenosis, but asymptomatic patients. Should we wait or should we do something? So, I am Dr. Ashish Mohapatra, working as a senior consultant in interventional and structural cardiology in Germany. So, coming to the discussion, a patient is coming to us with severe aortic stenosis but asymptomatic. What should we do? It's a big question now. Should we wait and watch and do the follow up visits with echo measurements? Or should we intervene? If we intervene, then when should we intervene? That's why I chose this topic to do a prospective study and analyzing the watchful waiting and early intervention strategy in severe aortic stenosis patients without symptoms. What is exactly severe aortic stenosis? Asymptomatic patients, basically, it's a clinical conundrum. In deciding upon the best therapeutic strategy, vigilant waiting, or early intervention. This prospective study compares the results of the benefits of watchful waiting versus TAVI in patients with asymptomatic severe aortic stenosis. Till date, there are a number of trials has been done, but not a single trial considering the TAVI versus conservative watchful waiting strategy. Though there are number of trials are going on, we have to wait for coming years to get the result. What I consider in the watchful waiting, it's like monitoring a patient's scheduled examinations on echocardiography to recognize disease progression or the emergence of symptoms necessitating action. What are the pros in watchful waiting? Like preserving the natural valve, avoids the dangers and consequences of invasive procedures. But cons? Threat of the disease development, which may result in symptoms: heart failure, as you all know, impairment of the cardiac anatomy and functions, and most important thing we do forget always by treating patients: psychological impact of continual observation and delayed treatment if symptomatic. Then what is in the TAVI arm? What is the actually TAVI? We should know that beforehand. It's a typically reserved for the symptomatic patients as per the guidelines, as per the treatment strategy, whatever is following. Increasing interest as an early intervention options were selected asymptomatic high risk patients only, not for the all patients. What are the pros in TAVI? Like it's a very proactive approach, a minimally invasive transcatheter procedure, prevent cardiac anatomical and functional abnormalities if we do it, prevention and reduction of the hospitalization, which is a very cost effective aspect if we consider. Considering the cons in TAVI, it's like about the procedural risk like AV block, permanent pacemaker implantation, patient prosthesis mismatch, annular rupture, coronary obstructions, and so on. Valve related issues, need for the long term follow up, and valve in valve possibilities. These are the cons. So, as per the ACC, American College of Cardiology and American Heart Association 2020 guidelines on valvular heart disease, they have considered asymptomatic severe aortic stenosis as group C and further divided into group C1 and C2, as you know here. Depending upon the LV systolis function. According to the ACC guidelines 2020, if we consider no aortic stenosis symptoms, they consider the stage C as I discussed, and TAVI is also they consider at stage C. Then what's the guideline is saying? As per 2020 guidelines, They are considering as the 1B for C2 patients and 1B for C1 with other indications for cardiac surgery. As the intervention strategy, in asymptomatic patients, as you see here, with severe AS and LVF less than 50% and less than 80%, they consider the TAVI, and 1B for the asymptomatic patients with severe AS and abnormal exercise test, severe AS rapid progression, and elevated BNP, also an indication for ABR. Whereas they have written SAVR is recommended in preference to TAVI. But in this case, we can perform TAVI. As per the 2021 European guidelines, they are saying interventions should be considered in asymptomatic patients with severe aortic stenosis and systolic LV dysfunction less than 55% without any other cause. This class 2A. This is a new guideline, and the revised guideline in comparison to the 2017, like interventions should be considered in asymptomatic patients with LVF more than 55% with normal exercise test if the procedural risk is low and one of the following parameters is present, like very severe aortic stenosis gradient of more than 60, severe valve calcification as per the CT, and the markedly elevated BNP level like heart failure markers, confirmed with the repeated measurements without any other explanation. Considering the trials, like early intervention, there are two trials in favor of early intervention in case of severe asymptomatic aortic stenosis. One is AVATAR, aortic valve replacement versus conservative treatment, and another is recovery trial. Both the trials showed like early surgery has improved survival, reduced a primary composite of all-cause death and acute MI and stroke, and reduced heart failure hospitalization. There are several ongoing trials in case of asymptomatic severe aortic stenosis, like early TAVR with 900 patients, which is going on, will be ended in 2032. Here, they consider early intervention alternate TAVI. In EVOLVE trial and EGAS trial, they are considering, there are also big trials considering early SHABA versus conservative treatment, and Danvers trial, it's with also 1700 patients. They are taking both the intervention like SAVR and TAVR versus conservative treatment. That's why I thought to do a small prospective study, keeping the TAVI into account and comparing the clinical outcome of the TAVI with those of the conventional management of watchful waiting in asymptomatic patients with severe AS. What is AVATAR trial? Its total patient of 157, distribution was 1:1, 2015 to 2021. SAVR better outcomes than conservative treatment. As you see here in the Kaplan-Meier curve, the mortality in case of early surgery is comparatively lesser than the conservative treatment. And here also you can see, in case of incidence of MES, in early surgery is definitely better than the conservative treatment. And what is recovery trial showed us? They took 145 patients into the study group and distribution is 1:1. 2010 to 2019 the study went, and early surgery was better than conservative treatment. Here you can observe the mortality is better in case of early surgery, and the incidence of the heart failure hospitalization also better in early surgery as compared to the conservative treatment. Now coming to the study design, we have taken the severe aortic stenosis patients. If they have symptoms, they directly went for SAVR or TAVR. If they didn't have symptoms, they came into the study group. We have taken initially 27 in 1-to-1 distribution for 54 patients, 27 in TAVI and 27 in conservative watchful waiting. Considering there are some limitations like non-compliance, only male patients included, no lab investigations, and the number readjusted to 25 in each group. Inclusion criteria like sex, male, age more than 70, echocardiogram, aortic valve area less than 1 centimeter square, P mean gradient more than 40 millimeter mercury, Vmax more than 4 centimeter per second, and ejection fraction more than 50%, and sign a consent form to participate in the study. Exclusion criteria are like associated coronary artery disease, symptoms like angina, dyspnea, syncope, ejection fraction less than 50%, regional wall motion abnormalities in echocardiogram, age less than 70 years or more than 90 years, presence of moderate to severe mitral regurgitation, previous bypass or any valve surgery, failed to sign the consent form. These are the exclusion criteria. The study was done from October 2021 to March 2022, compared 18 months, without any external funding. Study schedule were like the initial day, 0 month. We have the study parameters. Consider the study parameters like LV, global longitudinal strain, left ventricular mass index, left atrial volume index, and we, with the gap of 3 months, we measure these parameters along with the clinical examination, along with the blood pressure examination, blood pressure and pulse and ECG. Likewise, we 0, 3 months, 6 months, 9 months, 12 months, 15 months, and 18 months. The study design, considering the age parameter, like in the TABI group, there's 78 with standard deviation, two standard deviation of 7.8, and here you can see around 77. Aortic valve area mean were like 0.81 and 0.82 in watchful waiting. We have compared the TAVI versus the conservative watchful waiting. Then considering the first parameter like left ventricular global longitudinal strain, here you can see like is the 0 month, the start of the study, and every 3 months we have taken the measurements and plotted in the graph. The blue is TAVI and green is watchful waiting. You can see very clearly there is slow rise in global longitudinal strain of LV after TAVI, whereas there is slight declining graph of the watchful waiting. Then coming to the second parameter, left ventricular mass index. The left ventricular mass index, as it is only the male patients are involved in this study, the high LVMI was defined as when LVMI more than 115 gram per meter square of the body surface area. So here accordingly also, like every 3 months interval, we measured this LVMI, and TAVI here is also green, and TAVI is blue, and watchful waiting is green. And you can see here in TAVI there is decline on the left ventricular mass index after TAVI, whereas there is slight rising trend of the watchful waiting arm in case of left ventricular mass index, which further develop into the heart failure symptoms and so on. Then coming to the third parameter like left atrial volume index, LAVI. LAVI is an independent predictor of adverse events in patients with moderate or severe AS and preserved ejection fraction. The size of the left atrium is smaller in case of South Asian population, as the studies in South Asia country, as compared to the western part. For this LAVI, For this study, LAVI was considered as the normal when is less than 30 millimeter per meter square and more than 30 is considered as the decreased. Increased. If you consider here the graph, consider the 0 to 18 months, TAVI is the blue, and there's slow decrease in LAVI after the TAVA, whereas in case of watchful waiting, this is in a rising trend, very slow rising trend. So the follow-up measurements, the LAVI, LVMI, and LVGLS, we saw there is substantial improvement in each echocardiography parameter after TAVI in the case of asymptomatic severe aortic stenosis patients. In case of 12 months follow-up period, the LAVI regression was 15.48% and LVMI reduction was 11.83%, whereas left ventricular global longitudinal strain improved by 22.79%. Keeping in mind there may be observe a variation in different hospitals under different echocardiographic machines as it is a multicentric study. So patients with early percutaneous treatment TAVI had significantly better left ventricular and left atrial functions over the follow-up period than those who received conservative therapy. Furthermore, early intervention was linked to enhanced quality of life in these individuals. So conclude, based on the findings of the study, of this prospective study, like TAVI outperforms the watchful waiting in patients with asymptomatic severe aortic stenosis. TAVI significantly improves cardiac functional parameters, reducing the risk of adverse events, including heart failure and major cardiovascular events, while improving the quality of life. Although procedural complications were observed with TAVI, they did not outweigh the significant benefits observed. Therefore, TAVI emerges as a favorable intervention for asymptomatic severe AS, providing patients with improved outcomes and potentially preventing the progression of the cardiac dysfunctions. Further research and long-term follow-up studies were warranted to validate the findings and establish the long-term effectiveness, the safety of TAVI in this specific patient population. As you know, the studies are going on, what we have discussed in previous slides. So we have to wait till the result of these trials, early travel trial and so on. So it's better to intervene early rather than late, keeping the echocardiography parameters and the lab parameters into consideration, not only the symptomatic presentation of the patients. Thank you.